I'm Jean-Marie Okwo-Bele, medical doctor. I'm public health consultant, and I used to work with WHO before I retired, and I was director of the vaccines department between 2004 and 2017 at WHO headquarters. What we mean by co-administration of COVID-19 vaccine simply is that giving a COVID-19 vaccine could be done at the same visit as another vaccine. For example, influenza, pneumococcal vaccines, or other adult vaccines, rather than asking the person to come back another day. It does not mean mixing vaccines in the same syringe. It means giving them during the same appointment. And this is already something familiar with childhood immunization, where several vaccines are often given in one visit to protect children as early as possible and avoid missed opportunities. So in brief, I would say co-administration means same visit, not the same syringe. We already do this routinely in childhood immunization, and the logic is simple: protect people when they are in front of you. Well, the current evidence of providing COVID-19 vaccines together with influenza vaccine in terms of safety is broadly reassuring. Studies have been conducted and reviews have shown that giving those two vaccines, COVID-19 vaccine and influenza vaccines together, is generally safe, and the immune responses are largely preserved with no particular safety signals that one has seen from the available data. So overall, for influenza and COVID-19 vaccine together, the science is broadly supportive. The differences when vaccines are given at the same time versus separately are small. There are some studies that suggest that people may have slightly more local or systemic reactions, such as sore arm, tiredness, or mild fever. But these are usually expected and short-lived. The main point actually is that protection is not compromised at all. And in real life, the advantage of vaccinating at one visit often outweighs the inconvenience and loss to follow-up that can happen when vaccines are given separately. So the key public health message here is that co-administration is an acceptable strategy. You may get a bit more reactogenicity, but usually nothing major. Why is co-administration important for adult immunization program? Well, this is a good question because truly this is where co-administration really matters. Because adult immunization programs are still weaker compared to childhood programs in many countries. Adults do not come to clinics on a fixed schedule the way infants do. So when an adult comes for care, that visit is precious. Co-administration helps programs use that contact well: one visit, more protection, less delay, fewer missed opportunities. And that's exactly the same reasoning used in childhood schedules. Vaccines are grouped because it's more practical, more efficient, and it helps people become better protected on time. Actually, WHO life course immunization agenda points in this direction. Vaccination should not stop in childhood, and one should use the opportunities of visits by adults to provide them with as much protection as one could with vaccines that are available. How can co-administration improve vaccines uptake and system efficiency? Well, it can improve uptake because it reduces the burden on the person. You have fewer appointments, less travel, less time off work, fewer chances to postpone and eventually never come back. It also improves system efficiency because same staff, same cold chain session, same record system, and same community mobilization efforts that can help to deliver more than one vaccine at a time. And as we know, WHO's policy brief explicitly notes that co-administration can increase uptake by reducing vaccination contacts, and it can improve programmatic efficiencies. Several countries like Canada have noted that separating COVID-19 and influenza vaccine delivery would require more resources and more patient visits, and that's costly for the society at the end of the day. How are national immunization guidelines evolving regarding co-administration? I would say that at this point in time, the broad direction has been towards greater acceptance and normalization of co-administration. WHO has been quite outgoing with recommendations that support co-administration of COVID-19 and inactivated influenza vaccines, for instance. And in countries like UK, Canada, many others in the Western world, COVID-19 vaccine may be given concurrently with non-COVID vaccines generally. So the trend is towards integrating COVID-19 vaccination into broader adult and seasonal vaccination practice, rather than treating it as something completely separate. So in short, I would say the direction of travel is clear. Integrate where possible, and we have evidence that it works, and the operational logistic is very strong. In future, could co-administration become a standard strategy for life course immunization? Yes, that's the short answer. As countries move towards a life course approach to protect not only infants, but also adolescents, adults, and people of all the age, co-administration is likely to become more and more important. There are actually several approaches trying to combine, for instance, respiratory vaccines that can be given, as part of that co-administration. And this approach, this trend could be further reinforced. So yes, co-administration is certainly going to be a standard strategy, especially for seasonal and risk-based adult vaccination. My key message to policymakers about COVID-19 vaccine co-administration is this: please make vaccination easier, not harder. If the science supports co-administration, as we know in the example of COVID-19 with influenza vaccine, then national policies should help programs deliver protection in the simplest way possible. We learned this long ago in childhood immunization. When you reduce visits, reduce missed opportunities, and protect people on time, coverage of vaccination improves. And we believe that adult immunization deserves the same practical mindset.